Thank you, sir. Welcome, everybody. Like you said, my name's Cameron. I'm from Spokane, Washington. I know we're kind of doing this remotely. I've been in fire and EMS just about 8 years, and Sean was one of my original instructors that kind of got this ball rolling. Most of my career and volunteer and part-time work has been in the rural setting, and I kind of work in a half city, like half rural county department right now. So I'm a firefighter paramedic for them, and I've worked in Spokane for just shy of 3 years now. So the topic today I chose, like Sean said, the title is Busy Bee, but kind of anaphylaxis and allergic reaction, kind of recognition and treatment and stuff that I've seen in the protocols that I work under and kind of how I treat. And it's kind of a good refresher. I think you'll see as we get into this, there's a little spot in here where I talk about like how aggressive you want to be with treating either an allergic reaction and anaphylaxis. And I think there is a difference between the two. And we'll kind of dive into that. But this is just some of the key points that I have either seen or made mistakes on or kind of learned along the way. So with that, we'll dig into this. I have my chat box open, so I'll probably ask some questions as we go. If we have people that are involved and want to reply, that's great. Send the chat through or send the question through to the chat, and we have some other people watching as well. So away we go. So like I said, this is kind of based off of my experience, my interpretation and skill set, and off of my protocols that I work under. So if you're in a different state or a different county, that's my disclaimer, is don't take this and go run it back to your home department and get yourself in trouble. So that's not any fun. So kind of what I want to emphasize in this is the difference between what I think an allergic reaction is and an anaphylactic reaction. So an allergic reaction is generally located in one or two body systems that don't have any respiratory or cardiovascular compromise in it. That is okay. You can have an allergic reaction to, you'll hear in the books, it's a bee sting or a new food, but that can be a new medication. It can be a piece of tape, clothing, like laundry detergent can make people itchy and stuff like that. That can be an allergic reaction, and they will be totally fine. Their body will take care of it and heal themselves. They just might be a little uncomfortable. And sometimes we get called 911 or we get called for that, maybe to a school, a kid is having an allergic reaction or something. And it's not an anaphylactic reaction. It's not an immediate life threat. So I tend to kind of let what I think is an allergic reaction, kind of let it play itself out. I have hospitals that are close for transport time. The farthest hospital away that I can get to is probably 45 minutes or so. So I'm really relatively close with a good trauma center in town as well. So I kind of let those kind of ride out. I don't get too aggressive on what I might think an allergic reaction is. And it also helps with family or the nurse that's at school or even a kid who thinks he might be having this bad anaphylactic reaction, and really it's just kind of an allergic reaction. So you can kind of help calm the patient down, calm their family down, and maybe have some time to do some public education and try to figure out what might be causing this. So maybe it is a new laundry detergent, or maybe they do have to go follow up with their doctor, and you can avoid the ER and tell them to follow up with their primary care physician to get in there and maybe see what's causing this. So like I said, normally we do not treat these unless the patient, what I think, has a history of rapid deterioration. So this could be like, yep, I kind of had an allergic reaction to peanuts last time I ate them and nothing really happened, but this time it's getting worse. I'm getting short of breath. I just feel like this is not right. Or even the family says he has he looks fine right now, but he has a history of rapid deterioration. So and we kind of get into that with smaller children, or maybe there's a language barrier, or the patient might not be able to tell you what they're feeling or what they're experiencing, or be able to verbalize or communicate that they're in distress, or they can feel themselves starting to decline and like they're starting to kind of lose it. So some things to take into account. So what is anaphylaxis? So I pulled this, what a book answer is. It's a severe, potentially life-threatening allergic reaction. It can occur within seconds to minutes of an exposure to something you're allergic to. Really common is the peanuts or bee stings. You'll hear me refer to that, but just know that any of these allergens can be, pollen or a new type of, like a food dye or something like that. Anything can kind of tip somebody over. So a lot of times somebody will get exposed to an allergen. And the first time their body will kind of recognize and go like, whoa, I don't like that. I'm going to remember that for next time. I'm going to fight this off now and kind of be okay, but be in some distress. But next time I'm throwing everything I have at this thing and we're going to surround it and we're pushing it out because I don't like it. And that's called the immediate hypersensitivity reaction. So you'll have a little, you'll get an allergen or something in there that's irritating the tissue, and the body goes into overload and it releases histamines histamines and mast cells that grab that allergen or whatever's irritating and surrounds it to try to keep it from going anywhere. And that just makes this cascading effect and cascading system because the body goes into overdrive and wants to hit this thing. And that's what can cause your bronchoconstriction and vasodilation and vascular permeability, aka edema. So everything is going to start leaking out of the cells, out of the capillaries to try to contain it, swell it, and start pushing it out. So that's where you're going to get like swelling in the face and the neck, or maybe in the hands around the bee sting, because that's the body grabbing onto whatever that allergen is and trying to push it out and just get it away because it knows it's causing some issues. So what I think anaphylaxis is red hot, itchy skin and or accompanied with respiratory and or cardiovascular compromise. So that's where, okay, I ate some peanuts and I feel like I'm doing okay. And maybe I've got some hives or some urticardia or maybe a little bit of swelling, but now I'm having trouble breathing. Now we just went from an allergic reaction where we might be able to let this ride out and kind of see how they do to now we're in anaphylaxis. And me personally, as a provider, I like to think I'm pretty aggressive with treatment and everything. Now I'm going to throw everything I have at this thing to try to stop it where it is before that cascading kind of keeps going and this problem gets worse to a point where I can't fix it. And now this person is in real trouble. So big indications. I'll have some pictures at the end here. Swelling to the face, tongue, lips, eyelids, anywhere around the neck, anything that gets into the neck area. If it's on the hands or into legs, that's a long ways for it to travel. Still be careful with it. But if it's around the respiratory system or anything that's involving cardiac, I don't think you can, I've never seen it if you can get enough swelling around the chest or something like that to cause, like difficulty breathing, but you're definitely going to be checking lung sounds, check heart sounds. You're doing a full workup and a full assessment on these people when you can, when it's appropriate. I don't know if we have a lot of BLS or ILS or ALS. I've worked at all three levels and you have a scope of practice that you can work in. So be as in-depth and do what's right for the patient at all times. So if you have the time to do a good assessment before you have to get an IV started and get drugs on board, do it. Your baseline assessment is going to be huge with these people. Systolic blood pressure under 90. So you're going to have the bronchoconstriction and the vasodilation. These people are going to start going into shock is what it is. And they're going to start circling the drain. They're looking pale, even though they're flushed and red and itchy and stuff. But these people look like crap. Most people that are feeling like this will tell you, they're like, hey, I'm feeling like trash. And they're starting to circle the drain. Immediate treatment is needed now, or they're just going to keep crumping, and now you're behind the ball and you're trying to play catch up. So the justification, this is what I was kind of talking about, where you as a provider, depending on where you work and your protocols and what your doctors let you do, about how aggressive you want to be and how you want to treat this patient. So I say plain out, this depends on your provider level, experience level, comfort level, and relationships with docs in the hospitals. I think that's huge. Where I work, I'm very fortunate. Our doctors are involved with writing our protocols. They're great about answering phone calls if we need them on scene. They're also good about, after we hand a patient off and they have their time to do their assessment, about coming back and answering questions or teaching us up on either stuff we did wrong, stuff we did right, or what we could do better, or maybe like what they're looking for to be done pre-hospital sites. When we bring them in, they're ready to go. So with that, take that as you will, but provide in your scope of practice, inside your protocols, inside what you're allowed to do. Just treat the patient appropriately to the best of your abilities. So some of the common drugs we use in my system for an anaphylactic reaction is epinephrine, Benadryl, and maybe some albuterol. that's pretty standard across the board. There's some, if you're in the flight medic world, or if you're if you're, progress farther than that, there's more stuff you can get, right? There's copious amounts of drugs out there, but those are kind of the basic ones that we use. So I think it's important to know how the drugs work and what they do, what your dosages are before you give it to them. So kind of the first one we use is epinephrine. It's a sympathomimetic, and what that means is it artificially stimulates your sympathetic nervous system. So you're going in an anaphylactic reaction, you're going to get the bronchoconstriction and vasodilation. That's the huge one. That's where your blood pressure is going to start dropping. That epinephrine, it's a shot of adrenaline, right? So it kicks in your fight or flight syndrome, which is going to try to raise your heart rate, raise your blood pressure, might raise your respiratory rate, but it's going to kind of give that patient the push that they need to keep perfusing their body and keep perfusing like vital organs. So, like I said, this treats an anaphylaxis, or it treats an anaphylactic reaction, not an allergic reaction. So that's where I think it's a gray area, right? Like EMS kind of lives in this overall gray area. They give us a set of rules that we have to play in. But I think that's definitely a gray area. Like, this person's not too bad. We'll kind of let it ride and see what happens. Or I'm treating this hardcore. And if you're going to treat it to the full ability, right? So don't, if an adult dose is 0.3 milligrams of epi 1 to 1,000 IM, don't give them half of that. Give them the whole thing. Give them what I've seen, I guess people like be afraid to treat or to do what they're allowed to do. Give it to them if the situation calls for it. Like work within the realm. So the adult dose for epi 1 to 1,000 IM is 0.3 milligrams IM. That is just, I like the shot in the shoulder. I've only had a true anaphylactic reaction like 2 or 3 times where it's gotten this advanced where they're going to need a lot of treatment. But epi works great. P's dose for my protocol is 0.01 milligrams per kilogram, or like we all learned in EMT school, 0.15 milligrams, max dose of 3. And if you guys have in the chat here, do you guys have epinephrine kits like set up, or how many are BLS, ILS, or ALS? Kind of what am I working with here? So the providers, let's go the providers that are BLS. Do you guys have epinephrine kits set up, or are you drawing these up every time, or like the old school multi-dose vials, or are you just rapid transporting? What do we have out there? Draw out of our own vials, okay. Drawing up, okay. So are you guys using out of the vials or the ILS drop? Sweet. Auto kit for beads. Oh, nice. Okay. So the people using the actual vials, are they the vials or the glass tinctures? Because then you got 2 needles to deal with, and you got glass because you have the filter needle you got to draw with, or versus just the regular old plastic. Okay, vials, not glass. Great. Versus the vial, I mean, you can use the draw needle, switch it over to a nice IM needle, and away you go. So that's good. We have the same thing. We have them just in the vials. On our wildland kits, are kind of more of a BLS side. We have epi kits ready to go. It's got the 1 cc like TB syringe with the other needle taped to it and the draw needle taped to it. So they're set up, ready to go. Mistake that I made during my paramedic clinical time in the hospital, it was like day 2 or 3. I was gung-ho, got paired up with my nurse and was ready to go. And I was supposed to give this guy a tetanus shot. The nurse goes, she felt comfortable letting me do it. She goes, I have everything laid out on the counter. It's already in the system. You just got to go in and give the shot. So I grabbed the vial, I grabbed the draw needle, draw it up, tell the patient like, hey, this is going to sting. I'm giving you the shot. And I go to plunge it in, and it was like, I could feel the tissue cutting as it was going, and the guy was wincing. I'm like, man, I've never done this before, but that doesn't feel right. Like I've had shots, and it shouldn't hurt that bad. So I give the shot, and the guy goes, man, that stings. So I go back out, and I tell the nurse, I'm like, it just felt weird. Is it supposed to like pierce through? She goes, no, what color needle did you use? I said, well, the little red one. Well, I didn't know the little red one is the draw needle that's about half the size of a Capri Sun straw, and the nice IM needle that's nice and thin and long was right next to it, but it was like underneath a paper towel. So lesson learned there, use the right needle. I felt horrible for the guy because he probably had to be bruised and sore, and some things you got to learn the hard way. right? Luckily, it wasn't that big of a mistake, but lessons learned. So what is Benadryl? Benadryl is another one of our first-line drugs that we use for anaphylaxis. It inhibits the release of histamine. So I was talking about your body gets the allergen in, it doesn't like it, it starts releasing these mast cells to try to get a hold of it and block it, right? So those mast cells, that's what gets out of control and starts causing all the edema and swelling. And that Benadryl puts a stop to it. It kind of holds it off and says, okay, like enough's enough. We got it from here. It reduces the bronchoconstriction and vasodilation. So everything starts getting out of control and it comes in and just kind of hits the pause button and say, hey, we're good for now. We'll take it from here. Well, that got really blurry. So this is just a kind of a diagram showing the different angles for either an IM injection, which is straight 90 degrees in the shoulder. I'm sure everybody's done it, or at least practice on an orange or a nectarine or something at EMT school. Then you got the sub-Q, which is more like a 45-degree angle, and that's kind of just getting under the skin, getting into the fat layer a little bit. Then you have the intradermal, which is right underneath the skin. So that's like your TB test that you get in the hand. Or if they do in the hospitals, they'll do like lidocaine before starting an IV. They just barely get under the skin and administer it. So we want deep into the muscle because that's where the blood flow is. That's where the tissue is, right? So straight in, 90 degrees. It's always, especially with epinephrine, any IM shot or anything you're poking in, you should always aspirate beforehand. Even though it's IM or you might be doing it in the leg, the odds of hitting a vein or an artery are pretty slim. But on the chance that you do hit an artery or a vein or something in the shoulder and you slam this person with 0.3 milligrams of epi 1 to 1,000, and it's essentially going IV, now they're off to the races because they just got a huge shot of epinephrine. Now, if they didn't have cardiac compromise beforehand, they do now because it's going to be like they're running a marathon. So, good trick. Insert your needle. I mean, get it to the appropriate depth, get it IM, and then pull back just a little bit, make sure there's no blood, and then go ahead and administer. Another trick that I like to do is you grab the shoulder tissue or anything and kind of pull sideways, like pull it flat and over, and then go ahead and do your injection and your aspirate and inject the medication, and then let the skin flop back. I don't know if it works or not. Somebody taught me this, but it's like pulling the tissue apart. So your muscles stacked on top of each other, right? And we're going to borrow a popsicle stick off the wife's desk. So the muscle is sitting like this, right? So let's say we pull it apart and it kind of gives us a gap, like in between the muscle tissues. We drop the needle in, we pull it apart, and it kind of creates like a horizontal cavity. Once we pull it out and let the muscle go back, it almost kind of like caps it back off. And they say it can help keep the fluid in, and then you can massage it in from there. I don't know if it works or not. It might just be a style point. It could be an old wives' tale, but I've never seen an injection go, they pull it out and it just like sprays back out. I don't know. I don't know if that's the thing. I'm sure if you pumped enough fluid into the shoulder, you can do about 2 cc's per shoulder. It might happen, but if it's a tip or trick that helps somebody out along the way, go for it. I can't remember where I learned that from or who. So you can kind of argue any of these pictures to mild or moderate or severe reaction. So I would consider this a mild, reaction. They got some hives, they got some urticardia, but it's kind of isolated, right? Like it doesn't look like it goes into the arms. It might be on the back. Like this could be like a sun rash or heat rash, or this definitely kind of looks like a sunburn or something. You can kind of argue any of these pictures, but that's what I would imagine a mild reaction is. If somebody called 911 and showed me that, I would feel comfortable putting them on the cot and just taking them to the hospital. I wouldn't think, if I saw this, I would not expect this person to crash and everything to get out of control. I would say, okay, this is probably a mild allergic reaction. I don't think I'm going to do a whole lot, maybe some preventative stuff like start an IV and we're getting vitals and stuff like that. But I would not expect this to get too crazy. Hopefully. You never know though. Don't let it turn around and get you. So some treatment for mild anaphylaxis. This is basically all these calls start BLS. You can BLS all the way. And towards the very end of an anaphylactic reaction is where like some ALS stuff might come in. But for the most part, it's going to be BLS. ILS is going to take care of all of this stuff. So remember, Remove the allergen if possible. Scrape the stinger, remove the medication patch or the tape. This can be anything that might be causing this allergic reaction that could turn into an anaphylactic reaction. So if it's the piece of clothing or if they're still eating the food, tell them to stop eating the food. I had one call that was a total nightmare. It was a family that didn't speak any English at all, and it was part of their history and tradition. When a child turned 2, they could eat any food, anything. They could eat whatever. So this kid had ingested new fruits, new vegetables, new types of dairy, new types of candy, and he was an anaphylactic reaction from head to toe. We didn't know what was causing it. The parents couldn't communicate what it was. It was horrible. So we just had to look at the patient, treat it within our protocols, and go from there. And I think they were able to track it back to he was like allergic to goat milk, but this small child here you go, you can have whatever. And it could have been just a combination of new foods and new allergens that just totally tipped this kid over. Mild anaphylaxis or mild allergic reaction. So good catch. We can probably call this a mild allergic reaction. So like I've been preaching the whole time, anaphylaxis is where we're actually going to start treating. So this could be a mild allergic reaction, excuse me. So we're going to take some vitals, O2, titrate to effect, stabilize the extremity, keep the patient calm. We want to try to keep the heart rate down. IV IO access. IO is like last case scenario. So now we're starting to, this is right off my protocols. This is kind of where I would probably draw the line from, okay, this is an allergic reaction. Now we're into an anaphylactic reaction. Now we're going to start doing some serious treatment. I've never done this or seen it done, but it says apply a venous tourniquet above the injection site. So if it's in the hand, it's going to be up in the forearm here. Don't put a tourniquet on and start an IV in this arm. Pick the other arm, the unaffected arm, if you can. Sometimes you can't. Or look for a different IV site. Try not to go in this where it's already irritated or there's already swelling and stuff going on. It's probably going to be harder to start an IV too if the hand's all swollen and you're going for a hand IV. Administer 25 to 50 milligrams of Benadryl. And then I just threw in some of the PEDS dosages at the end of these for fun. It's 1 milligram per kilogram, max dose of 50. So a lot of these dosages and drugs are kind of medic proof and EMT proof. It's either like 1 full vial or a half a vial. They try to make it as easy as we can, or as easy as they can on us. So these are moderate, like it's looking worse. So I put the kid under here as moderate just because it's isolated to his lips. So this is what I'm kind of looking at. It's not into his neck. It doesn't look like it's down into his jaw. You can't see his tongue or anything like that, but I would consider this moderate. Like, okay, we're gonna be working on this person, right? Same thing over here. It's just isolated to the eyes, to the nose, nothing to the lips. Doesn't look like it's down into the neck. There's no redness on the neck. It looks like it's just isolated right here. So this is probably very uncomfortable, but they might be okay with just kind of letting this one ride, but be prepared for this to go sideways. Anything, excuse me, anything with the mouth or the throat, intubation is going to be tough. There's already going to be swelling going on. It can squirt back out if it's place of Q. Okay. Oh, I just saw that one. It just popped up. Sorry, we got a little behind on the chat there. I scrolled down. Like I was saying, any intubation or airway control is always going to be a first priority. Remember your ABCs. Airway is going to be a huge thing on these ones. So be prepared for a difficult airway. Our treatment for moderate, like anaphylactic reaction. So we've got like mild, moderate, and severe, right? So now we're aggressively going to be treating this patient. We're going to the hospital, whether they want to or not. We're going to be doing some treatment. So there's multiple body systems involved. Maybe they got some shortness of breath. They're looking like crap. So it's all the treatment for a mild reaction. Remember, we're scraping the stinger. We're keeping the patient calm. We're trying to isolate the extremity. Now we're going to hit them with some epi. So 0.3 milligrams of epi, 1 to 1,000. Repeat every 5 minutes as needed. You're watching your vitals, you're watching your heart rate, you're watching your blood pressure. If it's an elderly patient and they have a history of cardiac compromise already, and they're on beta blockers and stuff, there's a lot to take into account with repetitive dosing on epinephrine and stuff, and know that the increased cardiac strain could definitely turn into now you're having a cardiac event where they could go into SVT, they could throw PVCs. So it's not just you just give them these shots and we're done. There's a lot more that all kind of ties into these medications. Standard 25 to 50 milligrams of Benadryl. Everybody's heard, if you want the kid to go to sleep, give them a little Benadryl or put some Benadryl in their water and stuff. It does make people sleepy, so be prepared for that. People are stressed, especially kids. They're working. They will compensate, and then crash. So you give them stuff that can make them sleepy, they might just crump right over on you. And be prepared for people they're tired of fighting. They're tired of trying to breathe. Their body wants a break, and we're giving them a drug that can help put them to sleep, I guess, make them sleepy. So I wouldn't be surprised if they get sleepy. You got to try to keep them awake. Peds dosage for Epi 1000 IM, 0.01 milligrams per kilogram, max dose of 3. Like I said, the common is 0.15. The Benadryl dose is the same. If you're looking at doing IOs on people for an anaphylactic reaction, if they get stung in the arm, try not to be starting a humoral IO on this side. Look for something far away that's going to be getting the fluid in and working. So I consider these severe. So this one over here, she's got obvious swelling to all the face, nothing on the lips, but I think if you look close, you might be able to see some tongue swelling. Most people don't have their tongue right behind their lips, and it's kind of down into the jaw here. It's not into the chest, but it looks like it might be kind of starting to wrap around the side. So I would pull the trigger on this as a severe anaphylactic reaction, and we're treating. Is there a max dose of Epi for adults doing repeated injections? So in our protocols, no, I did not see anything. I would probably look at doing just 3 dosages, and then I'd be phoning a friend. If the treatments I'm doing is not working after like 1 or 2 times, call a doc. Like, we have a great relationship with ours. I'm not afraid, or I'm not like too proud to call or whatever. Phone a friend. That's what they're there for, right? The severe reaction in the little kiddo here. I don't know if this kid's just got chubby cheeks or not, but they look a little red. I hope they look red on your screen. It looks just like a little bit of rash, a little bit of swelling to the lips, and then definitely to the tongue. So this is going to be a difficult airway. We're doing a lot of treatment. Oh, I lost my chat. There we go. All right, treatment for severe anaphylaxis. All the previous treatment from above. Now we're looking at high flow O2. We're considering intubation. Prep for it. If you are going to go down the road of intubation, I would say do it early and resedate as you needed, and use your bougie tube. Have all your backup stuff ready, especially if you're getting any edema into the throat or into the neck or into the face, the tongue, like this. Let's see if I can go back. Like, child intubations are difficult already. Imagine trying to fit a blade and a tube in there to do your intubation. That's going to be difficult on a good day, and now they're having issues. It's not going to be fun. Cardiac monitors, we're looking at 4 leads, 12 leads. If they're crumping real bad, put the pads on, get everything ready to go, right? I'm very lucky. I work for a county that is, we're going to do everything we can, and we worry about the bill later or who's going to pay for it. So we're going to roll out the red carpet every time. So the patient deserves the best, and hopefully I can give them that. We're looking at IV-IO infusions for hypotension, right? So slow IV pushes for Epi. This is a different Epi concentration. So this is an adult dose. So this is Epi 1 to 10,000. So this is the cardiac Epi, the stuff that comes in like the tannish brown boxes is 1 to 10,000. So the stuff that goes IM is 1 to 1,000. Think of like a shot of tequila. That 1 to 1,000 is 1 shot glass full of tequila, potent stuff. This 1 to 10,000 is that shot of tequila diluted down even more to make a 1 to 10,000 ratio. Okay. So the 1 to 10,000 only goes in the vein. It's the stuff we have has to be pushed through IV. So we're going to be careful with this, because this is going straight into the vein, straight into the cardiac system, right down the body. So it's a slow IV push of the same dose, 0.3 milligrams. Repeat every 5 minutes as needed. For this one, again, there was no max dose of epi, unless I missed it in our protocol somewhere. But I would say probably after a couple rounds of this, you should be calling, or hopefully where I work, we're going to be close to the hospital, but we're still going to be phoning in and say, hey, our treatment's not working. Like, be prepared. Try to give them the heads up. This patient's crashing. This patient's intubated. We've done all this stuff, and it's being unsuccessful. It's not working. Hit them with 15 milligrams of Benadryl. We're going to go max dose on this. And then we're looking at 2.5 milligrams of albuterol, either via nebulizer or pouring it right down the ET tube, or having them breathe it on their own while we're getting IV started. And what this is for the bronchoconstriction, all the swelling and the edema that's in there and in the lungs. Everything is tight and clamped down, basically like an asthma attack. Essentially, everything is clamped and full of snot. So the albuterol is going to try to help open that up and maybe make airflow a little bit better, make the oxygenation a little bit more effective than having to breathe through a tight straw. We're going to try to dilate it out a little bit. Would you consider a nasal pharyngeal airway earlier on if you can't sedate for intubation? So let's go for the kiddo here, or any of these. A nasal pharyngeal if you can't sedate for intubation. That's a great question. Yeah, I mean, take whatever you can get. I mean, MPAs, OPAs. I mean, if you can, if you can't sedate them, yeah, go ahead. Consider it an airway if you're getting ventilation with it as well. If you're getting good oxygenation and some ventilation, that's perfect. Keep it basic. We don't need to try to put tubes in places that we might not be successful at. So if it's working and it's a patent airway, fantastic. I say go for it. Great job considering that. Does that answer the question there from Embry? Good? Awesome. Good idea. Good call. Sometimes that's why we work in crews, right? Somebody might have the idea and you got to be able to say like, hey, you know what? That's a great idea. Let's go ahead and try it. So it happens. We're all part of this team that goes out and stuff. Some stuff does fall on the medic to actually do it, because that's what we have the license to do. But it takes the EMT that's been there for 35 years to say, hey kid, listen, like I've seen this before, like here's what we can do to save you a whole lot of headache. And that would be a perfect example of it. I talked about albuterol. So peach dose epi of the 1 to 10,000, 0.01 milligrams per kilogram, IVIO. This stuff is not going IM, remember? Max dose of 0.3. So all the dosages are really quite the same. Benadryl, 1 mg per kg, max dose of 50. And then peds fluid bolus. So if they're hypotensive, we have little flip charts or like hand tevi that tells us, you know, what an average height and weight should, or even the Brazel tape. I know we're kind of getting away from that, but that's a good, if you got nothing else to guess what would be an average set of vitals or an average height or an average weight, it's better than nothing, right? So a 20 milligram or 20 milliliter per kilogram fluid bolus for their minimum blood pressure for their age. So in hand tevi, I could put in their age and it would pull up their, what would be the assumed like weight and height and all these drug calculations and everything. And I would bolus them to get to that minimum blood pressure, right? We don't need to fluid overload people that are already having trouble with third spacing or constriction and stuff. So, man, I definitely flew through this. So overall, I'm saying be as aggressive as you want to try to do what's best for the patient. Work within your means, work within your scope of practice and what your rules are and everything. But overall, what we're here for is to do what is best for the patient. Man, I absolutely flew through that. I apologize. Does the IM dose of 0.3 at 1 to 1,000 last longer than the IV dose? Yes. So the half-life on that is a little bit longer since it is going IM. The time of onset and the time of duration are longer. So it's used in the appropriate setting. The 1 to 10,000 is straight into the IV, straight into the vascular system. So that's going to hit a lot faster. More questions?
It's got to be some kind of record, man.
Yeah, man, I did. I apologize. I absolutely flew through that.
Does anybody have any, I mean, we got lots of extra time. So does anybody have any questions for Cameron when it comes to anaphylaxis, maybe calls you've been on or patients you've encountered? For this one, if you want, I think there's a raise hand option, which will allow us to like physically call on you so you can unmute your mic. If that's a little bit easier than trying to type.
Can you hear me?
Yeah, Bill, go ahead, sir.
So I've been around a couple of mastocytosis, and it presents itself as an anaphylactic type reaction. And I've had pretty good luck with epi, but I don't know if you can shed any light on that.
I didn't catch the first part of that. You kind of cut out. What was it?
The mastocytosis.
Mastocytosis. That's a new one for me.
It's are you familiar with it?
I'm not as well, Bill, so why don't you enlighten us a little bit and we'll see what we can answer for you after that.
Well, it's just a reaction, and severe. It can be like anaphylaxis, where they just can react to anything, nothing in particular. And it causes a full body reaction similar to anaphylaxis from peanuts or bee stings. And it's really scary, especially people on new drugs can have that, where it really concentrates around their neck and trachea and stuff. So I didn't know. I've dealt with it twice, and it's always a damn scary one.
Yeah. I don't know. That's a new one. So if it's a kid or somebody that's familiar with it, like we always hear, the parents, are the best patient care providers for sick people. Maybe seek their input, or again, I'd be calling up the doc if you can't get them on the cell phone. Try to get them on the radio, and that's probably a good one to bring up to your EMS lieutenant or your medical side of people. Say like, hey, I've run across this a couple times. Can we get some more education on it? Or maybe there's that one specific patient that lives at this house. Everybody knows them. This call goes sideways every time we go on it. Maybe you can come up with a set of protocols or what you're going to do to treat them. So we've had a couple kids that are super sick, or they have a special drug. We get trained up on it. The parents know that we're trained up on it. We have a plan that takes care of it. Are there other uses of epi besides treating anaphylaxis? Yeah, absolutely. So epi is epi, right? It's just kind of different concentrations. So you can have your like the anaphylactic side, you have your cardiac side, you have like shock. It's used as a pressor. Like there's kind of all sorts of uses really into the cardiac side of stuff, because that's where that drug primarily works and affects. But there's different dosages too that affect different things. If you want to affect, maybe one specific part of the cardiac cycle. Actually, I'm just kidding. That's dopamine. I got off on the wrong drug there. But yes, there are other uses for epi. I caught myself there. My apologies.
Do you want to chat a little bit just on racemic epi and kind of the power application of that one, just as we're kind of talking about epinephrine, Cameron?
What's that? I was trying to read the.
No, you're fine. Talk about racemic epi and just kind of the benefits of racemic epi when that might be utilized. I mean, most of the people logged on here are going to be at the BLS, but you want to we're talking about epinephrine. So just the use of racemic epi when it comes to those, especially those pediatric cases with shortness of breath and difficulty breathing.
Yeah, since I caught myself on that last drug, I'm going to pull this up. I'm not trying to steer anybody wrong here.
You're good.
Okay, racemic epi and the peds population. Severe respiratory distress. You're getting into the stridor. You're getting into the wheezes. It's there. It comes in the little packages and the little vials. It's a big bang for your buck. Man, you might have to help me out with this one here. I'm sorry.
No, you're fine. Racemic epi really is going to be those upper airway obstruction when it comes to, we definitely think about it like with croup and things along those lines. Like Bill said, yeah, severe asthma might be a good benefit. I think like the PAIRS and PHTL, or not PHTLS, sorry, PAIRS program from the Pediatric Emergency and Assessment Recognition, and like PALS kind of talks about the use of some of that like nebulized epinephrine to kind of combat that upper airway obstruction. So definitely some other things to think about. I know I liked how you talked about the multi-dosed epinephrine, just because that's kind of the wave of where people are going. Obviously, EpiPens are expensive and expensive for EMS, so definitely something to think about. It is also an over-the-counter med, which is great. Absolutely. The other big one, if you guys are unfamiliar, but the 2019 scope of practice change is there is good conversation about bringing oral over-the-counter strength diphenhydramine down to the BLS level, which of course would give us some of that longer acting antihistamine. You know, epinephrine's great as a life-saving drug that works in a few minutes to reverse the side effects of histamine, but it doesn't combat that histamine release, right? It just combats the side effects. So anybody have any protocols? I don't know if anybody from the National Park Service is logged on tonight, but I know their EMTs can give oral Benadryl. Does anybody else have any protocols that allows you as EMTs to give the oral Benadryl to your patients after epinephrine is given? Trying to see if anybody chimes in that they've got the protocol for that. Bill's a no in Grangeville. Gonna take everyone's silence in that they don't have access to that, but definitely something to think about. I mean, yeah, Montana can with a medication endorsement, so that's good. Usually it's some of those, I think it's kind of designed for some of those longer transport times, you know, for you and I, Cameron, here in Spokane. I mean, you know, we'll be at the hospital well within the half-life of epinephrine, but you get some of these places, I think, where they're 35-minute, 45-minute or greater away from a hospital. Benadryl is definitely a good follow-up drug when it comes to epinephrine. Definitely something to keep in mind, though. Epi is that life-saving drug, right? Like it takes effect quickly. It reverses those side effects as quick as possible. And if you look at, like, I really like Spokane County's protocol. I think even the NREMT under contraindications for epinephrine there is none in a life-saving situation. So even if the patient doesn't have a known allergy, if they're exhibiting signs and symptoms of anaphylaxis, or like Cameron did a great job describing anaphylactic shock, then give them the epinephrine. There's really no side effects that are going to cause any adverse reactions. You know, I know of some people that talk about precautions with, you know, well, if they're tachycardic, then, you know, use epinephrine with caution. Well, one of the things that people who are anaphylaxis get is tachycardia. So the risks definitely don't outweigh the benefits. So definitely something to keep in mind.
Yeah, you're right. It says right in here under contraindications for epi in the adult side, none in the patient who needs aggressive resuscitation. So
yeah,
use that.
Yeah, you painted that really good early on of just be aggressive, right? It's a good drug. Don't be afraid to redose if it's needed. If you need to call medical direction, call medical direction. And like Bill was saying, even with I already forgot the name of it here, the mastocytosis. If you have a presentation like that, we all have online medical direction, you know, at our fingertips. I know some of you are thinking of areas in your response area where you don't have cell phone service or something along those lines, but a lot of us have access to a physician, or at least a number we can call to get a physician to ask some of those tough questions of, you know, hey doc, what do you think? You know, I'm sure Cameron would admit, just like me, that it doesn't happen very often, but I've called the doctor with just, hey, we're looking for some guidance here. We've ventured into some uncharted territory, and we'd really like a professional mom to tell us.
Yeah, if I'm phoning a friend, I have run out of ideas. The crew's run out of ideas. My apps have run out of ideas. So we are in plan.
That's a lonely place to be.
It's a humbling spot to be. You're calling doc, and sometimes they have the answer for you, and sometimes they say, well, drive faster, and you just got to poo-ha. Sometimes high flow diesel, man, can cure a lot of things.
Yeah, for sure. Well, if there's no more questions, do you want to go over your, oh, look at that.
I'm gonna write this
Yeah,
down.
I have the Mayo Clinic up on my screen of what systematic mastocytosis is. I was trying to see if it had, you know, I
You know
figure
what's gonna happen is tomorrow on shift, I'm gonna run on somebody with this.
I wish that upon you. I hope it's a quiet shift. Um, it looks to be fairly similar um, to anaphylaxis. I mean, I don't know. I mean, yeah, it's kind of crazy that we've never heard anything like that. I mean, you look at the signs and symptoms, and it's flushing, itching, hives. I mean, basically all your typical signs and symptoms of anaphylaxis. So, I would say if it looks like anaphylaxis and smells like anaphylaxis and sounds like anaphylaxis, I'm going to give epi and then just claim ignorance after. So,
Yep. If you hear hooves, don't expect zebras, right? So
yeah,
I would probably treat that, and you could be able to justify that too. If a doctor does give you a hard time, you go, "How come you didn't know this was mastocytosis?" And you're like, and if you do your treatment based off your protocols, and you can stand behind it and stand there and defend it, most of the time they're not going to give you any grief. And if they do, you know that you did what was right, what was within your protocols, in your scope, all that stuff, and you can go home at the end of the day feeling okay-ish about yourself.
yeah, like I think I even have a slide somewhere in a slideshow that says choose what you'd rather defend. So if I'm standing in a courtroom trying to defend why I gave epi to a patient who looked like anaphylaxis, I'm on board with that. Then standing in a courtroom trying to find out why I didn't give epi to a patient who appeared to be anaphylactic. So I'm on
I
board with
agree.
that. Do you want to go over your post test?
Yes, this is.
I had a question.
What do you got?
Well, I was asking about somebody that gets stung on the tongue or in the mouth, and you get a lot of severe local swelling that's really just an allergic reaction, but it's not anaphylaxis. Would you go ahead and treat it as if it's anaphylaxis as far as giving epi or anything like that?
I'd probably, at the ALS level, I'd probably just start with some Benadryl and see where that gets you. And we're going to be transporting. But if they, like the bike rider that gets stung on the lip by a bee and it's isolated to just that, their airway's intact, they're ventilating fine, their SATs are fine, and there's nothing else going on, use your judgment, right? Like, I know that's not a defined answer, but do what you think is best on there. Maybe start with just some Benadryl, or pull the trigger and say, you know what, nope, I'm not letting this get out of control, and I'm going to do the epi and the Benadryl and run away with it. And that will probably take care of it just there, if it's just isolated to one spot. Now, if they were riding along on their bike and they caught a wasp in their mouth and it stung all around and lit them up, now we're into a whole different thing. They're going to have swelling probably all over the place, and that you could treat and be just fine enough. But
All right, thank you.
Yeah, great question. Where are you from? Your name doesn't show up when you.
Grangeville.
Oh,
Spring.
perfect. Awesome.
Yep.
All right, Cam, go ahead and go through your questions, sir.
So, is it frozen?
Oh, look what you've done. I can pull it up if you need me to.
Hold on. Wait, my escape button didn't work, but I think this did. We're working. Come on. I want this to go away.
There you go.
So sometimes I like a Mac, sometimes I do not. Whoa. Nope, that's not it. Okay, can everybody see that? I guess I'll just read it out loud. That's not how that was supposed to go. So I can't view my chat either, so Sean will have to help me out or just call it out. So number one, true or false, an allergic reaction involves multiple body systems and is life-threatening. An allergic reaction involves multiple body systems and is life-threatening.
I got an F in the chat. I got a false.
Sweet. Oh, and I just got this back up. Cool. I would agree. An allergic reaction, we're probably looking good. It's not life-threatening. We're probably okay. Number two, true or false? Epi for anaphylaxis may be given multiple routes. Epi for anaphylaxis may be given multiple routes.
Got a true from Grangeville.
Yep, I would agree. You can go IM, IO, IV, all that stuff. True or false? Benadryl is a sympathomimetic. That was a big word I threw out at the start.
Hey, I'm impressed. I think even from your advanced EMT, I don't think I can pronounce that word still to this day. So you're,
I struggle with a few of them.
that was just the word.
Yeah.
I'm trying to think. Yeah, it looks, Michael says false.
Yeah, I'm kind of seeing a little mix. I might have got them.
Yeah, I see some trues and falses.
Yeah, so Benadryl is not a sympathomimetic. Yeah, false.
And those trues may have been from the last question. I didn't see who was the last true to throw up there. So
fair enough. So false. Benadryl is not a sympathomimetic. Remember, epi is. That's where it kicks in your fight or flight syndrome. You get a surge of adrenaline. Your heart rate goes up. Hopefully, your blood pressure comes up with it. That's why we're giving it. It's stimulating that sympathetic nervous system synthetically. So it's a sympathomimetic. Benadryl is not that. True or false? Anaphylaxis should be treated appropriately and aggressively.
True from Steptoe Fire. They jumped in.
Yep. I would agree. Number 5, true or false? Anaphylaxis is only a result from bee stings.
And that's a bunch of falses. I don't know if you can see that, but.
Yep, I would agree. So that's just the big thing with those that I kind of hit. Every book or whatever you read talks about the peanuts and bee stings, but it could be anything that could cause an anaphylactic reaction or an allergic reaction that progresses into anaphylaxis. So take into account the new foods, like laundry detergent. I've seen that a couple times. It just amazes me. I get it from pineapple. Yeah, okay, new foods. It can be anything that causes the change. And sometimes it's on the person to recognize, like, oh, we went out, I tried a new deer hide. People will be like, I tried a new type of tea and I'm starting to get all itchy and everything. So you kind of got to do some like police inspection to try to figure out what's going on.
I think I only get anaphylaxis with pineapple on pizza. It's just when it's on pizza. I don't know what to do with it.
That's the best time when it's on pizza, man.
Yeah, erroneous. All right. Well, if you guys have any more,
I'm sorry. I absolutely blew through that.
No, you're good, dude. You're solid. I'm sure everyone is upset that on Thanksgiving week you send them home a little bit early. So, couple things. Don't forget to submit the rosters. Please also jump onto that SurveyMonkey link right there from our website and give Cameron some feedback. I think this is his last presentation with us, except for I got some open dates still that if he wanted to come back and teach again, I'm sure he would. I
think I've got one in December.
Oh, do you?
I've got the
you do. Oh yeah, you got ironically just before Christmas again. So Cameron's not gone, so he could come back on the 23rd. Between now and Cameron, though, on December 8th, same time at 6:30 start, Maurice Wagner is joining us for sports-related head trauma. He's got some, if you ever heard Maurice Wagner talk, he's awesome. I know Bill had him up at the Spring Fling Conference last year, so he's an awesome speaker, does a really, really good job. So come back for that one. Cameron, I appreciate you joining us from our long friendship and seeing you in class and the many times you've thrown me in the penalty box. I appreciate you joining us, and we look forward to having you back on the 23rd, man.
Yeah, that's awesome. Am I ready I can stop my share? Or?
Yeah, you're good.
Awesome. Okay. Well, I